Welcome back to the deep dive. We take that stack of sources you've shared, we distill the crucial knowledge, and, well, we cut straight to the surprising insights you need.
And today we're grappling with something of a surgical paradox. It's a real irony, actually, built into the very process of healing.
Hmm,
We're diving deep into a condition that is, pretty much by definition, an unfortunate result of medical intervention itself. The incisional hernia.
that's right. And this isn't just, a simple lump under the skin. It's a failure of structural engineering, really, inside the human body after surgery.
It really is.
And the scale of this problem, it's huge. And the science needed to fix it is so complex that, well, it remains one of the really big challenges in modern surgery.
It's a profound structural failure, absolutely. So an incisional hernia, if we're being formal, is the abnormal protrusion of tissue. That could be bits of intestine, internal fat, maybe the omentum, poking through a defect in the layers that make up the abdominal wall. And specifically, it happens right through the musculofascial layers at the site of an old surgical scar. Could be a long cut, a laparotomy, or even, those tiny keyhole port sites from minimally invasive surgery.
And here's why this deep dive really matters for, well, anyone focused on surgical outcomes or patient care. The incidence rates are, honestly, they're kind of unacceptable. This is not some rare fluke thing.
No, not at all.
Our sources highlight stats showing the incidence ranges. Well, it's wild. Starts maybe around 10%, but it can climb as high as 50% after certain big laparotomy incisions.
50%. Just think about that for a second. Up to half of all patients having certain types of major abdominal surgery might eventually develop this structural failure.
Wow.
And even with modern keyhole surgery, which is supposed to be less invasive, those small port sites still carry a risk. It's persistent, maybe 1% to 5%. It just confirms, doesn't it, that the incisional hernia is this huge ongoing challenge. We're constantly trying to figure out how to improve the body's response to being, well, cut open.
So our mission today is pretty ambitious. We're going to unpack the three main areas of risk: the patient, the wound itself, and the surgeon.
The triple threat, essentially.
Exactly. We'll detail the critical, specific, modern guidelines aimed at preventing this, focusing on really precise things like the 4.1 ratio. And finally, we'll really get into the weeds with the complex material science and the mechanical placement of mesh technology, because that's really the cornerstone of successful repair these days, isn't it?
It absolutely is. But maybe let's start by understanding the fundamental biological flaw. What makes this condition so common in the first place?
Right, because when we talk about healing, I think the typical assumption is that the body gets back to being good as new.
Yeah, that's the hope.
But our sources make it really clear that after a major abdominal cut, the wall is, well, it's fundamentally and permanently weakened, even if the scar on the outside looks perfect.
That's the crucial starting point. The weakness, the sort of inevitability of some level of failure built right into the biology. Even if the surgeon does a flawless closure and the wound heals without any infection, that repaired surgical scar, it only ever gets back about 70% of the initial undamaged strength of the original fascia.
Only 70%. Why? Why does the body just stop there? Why can't it rebuild back to 100%?
It really comes down to the chemistry of the tissue itself. Your original healthy abdominal wall, it's made of these strong, really nicely oriented type I collagen fibers. Very tough.
Okay.
But when the body repairs a wound, it fills that gap mostly with disorganized, much weaker type 3 collagen, that scar tissue. And that difference in the collagen type, the structure, that's the biological reason for that permanent 30% strength deficit. So any pressure later on, coughing, lifting, straining, it's pushing against a structure that's guaranteed to be weaker than everything around it.
Okay, so a 30% reduction in strength is the baseline, the unavoidable starting point. Now let's talk about the factors that push on that weakness. Our sources call it a triple threat, right? Intrinsic biological factors, mechanical factors, and human factors.
Exactly. Let's start with the patient factors, or what we call intrinsic weakness. There's actually incredibly strong evidence now that hernia formation in general, not just incisional, is often fundamentally a kind of collagen disease.
A collagen disease, that
Yeah.
that suggests it's maybe genetic, not just about the surgery itself.
Precisely. It implies there might be an inherited imbalance, maybe in the ratio of type 1 to type 3 collagen, favoring the weaker type 3, even in areas that weren't cut. And this isn't just a theory. There's histological evidence, looking at tissue under the microscope showing this altered collagen makeup in non-hernia areas of patients who are at high risk. And it definitely links to known systemic collagen disorders.
Right. I remember the sources mentioning extreme cases like Ehlers-Danlos syndrome.
Yes, exactly. In conditions like Ehlers-Danlos, where the connective tissue is just globally faulty, getting a hernia repair to hold long-term is incredibly challenging because the very framework the surgeon is trying to stitch together is inherently weak. It's like trying to sew tough fabric with thread made of wet paper.
Wow.
Now, Ehlers-Danlos is rare, obviously, but the underlying idea, that sort of genetic predisposition towards weaker connective tissue, that's probably much more common than we think.
And beyond genetics, lifestyle choices. They play a massive measurable role, too. Smoking is always listed as a key risk.
Oh, smoking is critical. It's a really significant self-inflicted risk factor. Nicotine, as you know, is a potent vasoconstrictor. It narrows blood vessels,
Right, less blood flow.
reducing oxygen supply, nutrient delivery, everything the healing wound needs. But even more specifically, smoking directly messes with the function of fibroblasts.
Okay, what do they do?
Fibroblasts are the cells responsible for making and maturing collagen. So if your body can't properly lay down and organize that collagen framework in that already weakened 70% scar, well, the risk of it just failing goes up exponentially.
So you've got this potentially weak foundation, and the next big challenge is the mechanical factors. This is all about pressure.
It's all about pressure. The
Yeah.
human abdomen, it's designed to contain internal pressure, but when that wall is compromised by a scar, that pressure acts like a constant stress test. We naturally operate with a relatively high positive pressure inside the abdomen compared to, say, the chest.
Okay.
So anything that spikes this internal pressure
Yeah.
is essentially trying to push the internal organs out through the weakest point, the scar.
And the usual suspects here are...
Well, high body mass index, obesity, that's the big one. It creates constant high internal pressure day in, day out. Then you've got the intermittent sharp spikes, like a chronic cough, which is common in smokers, obviously. That delivers these repeated violent pressure jolts against the healing tissue.
Right.
Even things like chronic constipation or doing really high impact exercise too soon after surgery can contribute. And let's not forget malnutrition. If the body doesn't have the building blocks, it can't generate strong, healthy tissue in the first place. That compromises the quality of the repair right from the cellular level.
So we've got potentially weak tissue constantly being pushed by high pressure. But the third factor, and maybe the most frustrating one, is the surgeon factor. This is cited as a major and potentially preventable risk.
Highly correctable, yes. This comes down entirely to the technical execution of the original closure. How was that first incision sewn up? If the surgeon uses poor technique, maybe the wrong suture material, or closes the fascia under way too much tension, they're basically building a fault line into the structure from day one. Yeah. And this realization that the method of closure is a key factor in later failure. Well, that's what's really revolutionized abdominal surgery and driven this whole search for specific, standardized closure guidelines.
Okay, now that we understand the sort of mechanics of how these things fail, let's look at how they actually show up, the clinical presentation. It's often thought of as just a simple lump, but it can be more complicated.
Yeah, the presentation can vary quite a bit. Sometimes it is that classic localized swelling right along the scar line, maybe pops out when you stand up or cough and goes back in when you lie down, reducible.
Right.
But critically, it can also be much more subtle. Sometimes it's just a diffuse bulging along the whole length of the incision, something you might only really notice when the patient strains or tenses their abs.
And our sources pointed out something crucial that surgeons often find only when they operate.
Yes, exactly. Surgeons frequently discover multiple separate defects within the same scar tissue. Little holes or weak spots that weren't obvious from the outside, you couldn't feel them. It just shows that the structural failure is rarely one single neat hole. It's often more like a series of weaknesses scattered along the entire length of that compromised fascia.
And finally, the really serious side, the difference between common obstruction and the much rarer but life-threatening strangulation.
Okay, so obstruction is pretty common with incisional hernias. This usually happens when stuff inside, often loops of intestine, gets tangled up, maybe with internal scar tissue, adhesions, or just gets temporarily trapped in the hernia sac itself. It causes significant pain, nausea, vomiting. But the key thing is the blood supply to the bowel is still okay.
Okay, uncomfortable but not immediately dangerous.
Right, but strangulation, that's the red flag emergency. This is when the neck of the hernia defect, the opening, is so tight that it physically cuts off the blood flow, the arteries supplying that trapped piece of bowel. Ischemia, exactly, leading to rapid tissue death. Now, incisional hernias often have quite wide necks. which actually makes true strangulation a bit less frequent compared to, say, smaller, tighter hernias like femoral hernias.
Ah, okay.
But when it does happen with an incisional hernia, it's usually because the edge of the defect has become really scarred down, fibrotic, and rigid over time. It creates this unyielding noose around whatever content is trapped inside, and that requires immediate surgery to prevent catastrophic bowel death.
That's a really powerful framework for understanding the risk. It's that combination, isn't it? Weak tissue, high pressure, and maybe technical flaws from the start.
So, if the surgeon's technique is a key risk factor and the patient's own biology can be limiting, well, the modern surgical approach has to focus really heavily on intervening before and during that initial operation. This is the art of prevention.
Okay, let's start with intervening before the first cut even happens. That's patient optimization, or this trend called prehabilitation. For elective surgeries, it sounds like we're not just rushing people to the operating room anymore.
No, the shift is quite profound, actually. For patients identified as high risk, the goal now is to stabilize them, strengthen them before they even get near the OR. This means mandatory, often quite aggressive, smoking cessation programs, sometimes starting months ahead.
Months. Wow.
Yeah, absolutely. And initiating supervised fitness routines, often focusing specifically on improving core strength.
And the benefits of weight loss.
Yeah.
The sources mention some pretty staggering, measurable benefits there. It must be a huge motivator for
Well,
patients.
they are significant. Our sources point out that losing just 7% of total body weight can lead to measurable, significant improvements in a patient's metabolic state. Better blood sugar control,
Yeah.
improved cholesterol levels, reduced inflammation generally.
Right.
But biomechanically, and this is the stat that really makes you think, losing just 5 kilograms of body weight, that's about 11 pounds, is estimated to increase the available space inside the average adult male abdomen by about 1 extra liter.
1 whole liter, just from 5 kilos. That's amazing. So that extra internal volume directly reduces that baseline pressure pushing out on the abdominal wall.
Exactly. It gives the eventual repair, or even just the primary closure, a tangible mechanical advantage before a single suture is even placed.
That seems like it should almost be a non-negotiable step for high-risk patients planning elective surgery.
It's becoming much more standard. It's the ultimate form of risk mitigation, really. So once the patient is optimized as much as possible, the focus shifts to the technical execution inside the OR, the science of optimal closure. And this is where we see the most revolutionary changes, directly tackling that surgeon factor.
Okay, so for decades, the standard advice for closing the abdominal wall was this near, or far technique, wasn't it? Sutures about 1 centimeter back from the edge and 1 centimeter apart. That was just taught as the way to do it.
It was standard, yes. But biomechanically, we now know it was flawed. It led to really high tension, concentrated at specific points. Think about it. When you place a suture far back, like 1 centimeter, and far apart 1 centimeter, all the stress of holding that wound together is focused right on those few points of tissue.
Right.
This leads to what surgeons call a cheese wiring effect. Imagine pulling a thin wire tightly through a block of cheese. It just cuts right through.
Ouch. Yeah.
That's essentially what happens to the fascia. The suture material simply cuts through the tissue it's holding, and the incision slowly starts to open up, often weeks or months later, leading to the hernia.
So the solution is actually kind of counterintuitive. Smaller stitches closer together for stronger, more durable repair.
Exactly right. The new guidelines, which are strongly endorsed by major groups like the European Hernia Society, they advocate for this small stitch, small bite approach. The recommended technique is incredibly precise now.
How precise?
Sutures should be placed only 5 millimeters apart, and they should grab tissue only 5 to 8 millimeters back from the actual fascial edge.
Okay, so much smaller bites, much closer together. That completely changes the geometry of the closure, doesn't it? It sounds like it's all about distributing the force.
It is entirely about load distribution. By taking these small, frequent bites of fascia, the tension required to hold the wound edges together is spread much more evenly along the entire length of the incision.
Ah, okay.
This prevents excessive stress on any single point, and that dramatically reduces the chance of that suture cutting out.
And to make sure surgeons are actually doing this, there's that very specific quantifiable metric that's been introduced.
Yes, and this is the absolute key metric now for assessing if a closure has been done properly. The suture length to wound length ratio. It must be maintained at 4.1.
Okay, unpack that 4.1 ratio one more time for us, because that sounds like a really critical standard for prevention.
Right. So if a surgeon has an incision that is, say, 20 centimeters long, they absolutely must use a minimum of 80 centimeters of suture material to close just the fascial layer.
80 centimeters for a 20-centimeter wound.
If they use any less than that, the ratio drops below 4.1. And a ratio lower than 4.1 mathematically proves one of two things must be happening. Either the individual stitches, the bites, are too far apart, violating that 5-millimeter rule, or the surgeon has pulled the continuous suture line way too tight.
Got it.
Both of those scenarios create high tension and directly increase the risk of the fascia tearing, the suture cutting out, and hernia forming later. By insisting on this 4.1 ratio, we're essentially standardizing a low-tension, high-frequency closure technique.
That's a fascinating example of applying engineering principles, really, to surgery. What about the suture material itself? Has that changed too?
Yes, the device has shifted there as well. We've moved away from the older, non-absorbable sutures, like nylon or Prolene for fascial closure. Sometimes those could act as a chronic foreign body, causing inflammation or even infection years later. The current recommendation generally favors a 20, slowly resorbable suture, something like PDS. This material keeps its strength long enough, we're talking weeks to months, to support the tissue during that crucial initial phase of collagen deposition.
Right, while the body builds that 70% scar.
Exactly. Then once the body has laid down its own structural repair, the suture material slowly dissolves and disappears. The idea is this reduces the long-term inflammatory response and potential complications from having permanent foreign material there.
Okay. And finally, in this prevention section, let's touch on what feels like the most proactive, maybe even philosophical shift, the emerging role of prophylactic mesh. Putting mesh in before there's even a problem.
This is a major paradigm shift, you're right. Historically, surgery has been reactive, right? We wait for something to break, then we fix it.
Yeah.
Now, particularly in very high-risk situations, we're seriously considering operating on patients who are currently fine, asymptomatic, simply because their statistical risk of developing a hernia later is so incredibly high, almost catastrophic.
So what are those high-risk groups where the calculation might favor putting mesh in preventatively?
Well, the sources mention patients undergoing certain types of bariatric surgery, where you have massive changes in abdominal volume and pressure dynamics, or maybe complex aortic aneurysm repairs, where a large midline incision is just unavoidable.
Okay.
But probably the most common indication right now is during stoma formation, creating a permanent stoma, an opening for bowel function onto the skin.
Like a colostomy or ileostomy.
Exactly. That procedure carries a risk of developing a hernia right next to the stoma, a peristomal hernia that often exceeds 50%. It's incredibly common and debilitating.
50% again. Wow.
So in these cases, the research is becoming overwhelmingly clear. Placing a prophylactic mesh reinforcement at the time of the initial stoma surgery can substantially reduce the chance of that patient developing a miserable peristomal hernia later on.
So we're essentially admitting that for certain procedures or in certain patients, the body's natural 70% repair strength just isn't good enough to withstand the long-term stresses.
That's precisely it. It's the ultimate biomechanical concession, in a way. We're using material science to augment human biology right from day one, instead of just waiting for the body to fail and then trying to patch up the complication afterwards.
Okay, this is where it gets really interesting for me. Once prevention has failed or wasn't possible and a hernia is present, the repair strategy shifts dramatically. It's less about just suture technique and more about material science, complex geometry, and understanding those anatomical layers. What are the core principles guiding a modern hernia repair?
Right, the principles are pretty non-negotiable now, mainly because the goal is to prevent recurrence. Simple suture repair as incisional hernias, historically, had recurrence rates as high as 30, even 50%. Just terrible.
Unacceptable.
Totally. So principle one, the repair must address the full length of the original incision, not just the obvious bulge or defect you can feel. Remember those hidden defects?
Right, the whole scar is weak.
The whole scar is compromised. Principle two, the edges of the musculofascial defect must be approximated, brought back together ideally with minimal tension using those same small bite principles we just discussed.
Okay.
And principle three, critically, prosthetic mesh must be used to reinforce and augment that closure unless, and this is a big unless there's obvious contamination like infection or bowel content spillage.
Okay, let's really dedicate some time to mesh technology because just calling it a patch seems to massively undersell the science involved here.
Oh, absolutely. We're not talking about patching a bicycle tire here. These are highly specialized polymers, engineered materials. Modern practice has overwhelmingly shifted towards using large pore, lightweight synthetic meshes. The most common materials are polypropylene, sometimes polyester.
Why lightweight and large pore? What was wrong with the older, heavier stuff?
The older meshes, which were often quite dense, heavyweight with very small pores, they tended to provoke a massive foreign body inflammatory reaction from the body.
Like the body really attacked it.
Exactly. The body saw this dense material as a major intruder and tried to wall it off by building incredibly thick, dense scar tissue all around and through it. Now, while this created a very strong, rigid plate initially, it also caused significant long-term problems.
And one of those problems was this thing people often call mesh shrinkage, but you're saying that's not quite right.
That is probably the biggest misconception we need to correct. The mesh material itself does not shrink. Synthetic polymers like polypropylene are incredibly stable. What we actually observe, and sometimes the mesh area can reduce by over 50%, is mesh contracture.
Contracture. Okay, what's that?
It's the natural, biological, progressive contraction of the dense fibrous scar tissue that the body deposits into the pores and around the fibers of the mesh.
Ah, so it's the body's scar tissue squeezing down on the mesh, not the mesh itself shrinking, kind of like concrete curing and shrinking as it hardens.
That's a really good analogy, actually. The body is essentially building this strong, rigid, fibrous plate interwoven with the mesh fibers. And as this biological scar material matures over weeks and months, it contracts, sometimes quite powerfully.
Okay.
And this severe contraction is what causes two major problems. First, recurrence, because the contracted mesh might no longer adequately overlap and cover the original defect. And second, chronic stiffness and pain, as this contracted, rigid plate pulls uncomfortably on the surrounding abdominal wall muscles every time the patient moves or breathes.
So the lightweight, large pore meshes are designed to minimize that intense scarring reaction.
Precisely. They allow for better tissue ingrowth, a more flexible, less inflammatory scar, better integration with the host tissues, and ultimately better long-term patient comfort and lower risk of that problematic contracture.
Okay, so material choice is key. But then placement is everything, right? We need to understand the different layers of the abdominal wall to grasp why some placements have a mechanical advantage.
Absolutely. If you imagine the abdominal wall in cross-section, you've got layers. Skin on the outside, then a layer of fat, then the anterior fascia, the tough outer layer covering the muscle, then the rectus abdominis muscle itself, your six-pack muscle, then the posterior fascia, the layer behind the muscle, and finally the peritoneum, which is the thin lining on the very inside, touching the organs.
Okay, got the layers.
Where you place the mesh within those layers fundamentally determines whether the repair will work with the body's internal pressure or against it.
So for open repair, the traditional incision, the sources strongly favor placing the mesh in the retromuscular plane, the sublay technique. Where exactly is that again?
Okay, so the mesh is placed between the back surface of the rectus abdominis muscle and the posterior fascial layer. So it's behind the main muscle bulk, and this is crucial, it's still outside the peritoneal cavity, away from the bowel.
Behind the muscle, but outside the inner lining.
Correct.
Okay. Why is that better?
This placement offers a definitive mechanical advantage. It's sometimes called the snow fence principle, or like Pascal's principle. The constant positive pressure from inside the abdomen, the pressure that caused the hernia in the first place, actually helps to physically push the mesh backwards, pinning it firmly against the strong posterior abdominal wall.
Ah, so the body's own pressure helps keep the mesh in place, like a reinforcing buttress.
Exactly. It acts almost like a stopper valve, held securely by that internal force. It works with the pressure.
Unlike the onlay placement.
Right. Onlay placement, where the mesh is placed superficially on top of the anterior fascia, just under the fat, well, it lacks that natural counterpressure holding it in place. Plus, to put mesh there often requires dissecting large skin flaps, lifting the skin and fat off the fascia.
Which sounds risky.
It significantly increases the risks of wound complications like seromas, fluid collections, hematomas, blood collections, and surgical site infections. The retromuscular space is cleaner, better vascularized, and mechanically superior.
Now, we also have to talk about a really common and dangerous surgical mistake you mentioned earlier, the bridging dilemma.
Yes, this is a fundamental error in judgment that almost guarantees a poor outcome, even if you use the best mesh in the world. This happens when a surgeon encounters a very large hernia defect where the muscle edges are far apart, and they decide to simply use the mesh to bridge that gap without actually closing the fascial edges together underneath it.
So they just stitch the mesh across the hole, leaving the gap open behind it.
Essentially, yes. They might anchor to the edges, but the central part of the mesh is spanning empty space. The problem is, while the mesh material itself is strong, it has no underlying support in the middle.
Right.
So inevitably, that constant internal abdominal pressure will push the unsupported central portion of the mesh outwards over time. The patient ends up with this soft, often quite large bulge where the hernia used to be. Surgeons call it a pseudo-recurrence.
Pseudo-recurrence, meaning the mesh didn't tear, but it just bulged out.
Exactly. The repair hasn't technically failed in the sense that the mesh broke or pulled away from the edges, but the functional result is terrible. It's floppy, cosmetically poor, and doesn't restore abdominal wall integrity. The principle is the mesh should reinforce closed fascia. It generally shouldn't replace it, unless maybe the overlap is absolutely enormous, far beyond the defect edges.
Okay, that makes sense. Let's shift to the minimally invasive side then. Laparoscopic repair, specifically the IPOM technique, intraperitoneal onlay mesh. This sounds tricky, putting mesh right inside the abdomen.
It is technically demanding, and it comes with its own unique set of challenges. The IPOM technique, done with keyhole surgery, involves placing the mesh directly onto the peritoneum, that inner lining from the inside of the abdomen. It's then fixed in place, usually with specialized tacks or sometimes sutures that go through the full thickness of the abdominal wall.
Okay, so the mesh is literally sitting inside, potentially touching the bowel. That sounds like a problem because standard meshes are quite sticky, aren't they?
Oh, absolutely. A standard polypropylene mesh placed inside the abdomen would be a disaster. It would immediately cause dense adhesions, sticking aggressively to the bowel loops, potentially leading to bowel obstruction or kinking.
So you need special mesh for this.
Yes, IPOM absolutely mandates the use of expensive, highly specialized tissue-separating or composite meshes. These are clever dual-sided materials.
How does they work?
One side, the side facing the abdominal wall, is designed to encourage tissue ingrowth, to stick and integrate. The other side, the one facing the bowel and other organs, has a special, slippery, non-adhesive barrier coating often made from materials like expanded PPFE, like Gore-Tex, or other specialized polymers designed specifically to prevent those dangerous adhesions.
But even with these special coated meshes, there are still significant trade-offs, right?
They are far from a perfect solution, no. Even with barrier coatings, IPOM carries inherent risks. There's still a risk of chronic bowel adhesions forming over time. There's a risk of the mesh potentially eroding through the bowel wall, especially if there's infection or pressure. And in severe cases, that can lead to a fistula and abnormal connection forming between the bowel and, say, the skin or another organ.
That sounds serious.
It is. And furthermore, those fixation tacks used to hold the mesh in place. They are notorious for causing significant acute postoperative pain. Sometimes the pain is so intense it can mimic peritonitis, making diagnosis really difficult. And worryingly, those tacks can also lead to chronic, long-lasting nerve pain syndromes for some patients, severely impacting their quality of life. It's for all these reasons, the adhesion risk, the erosion risk, the tack pain, that many surgeons are increasingly favoring techniques, even minimally invasive robotic techniques, that allow them to place the mesh in that preferred retromuscular space, getting it outside the peritoneal cavity altogether.
Right, trying to get the best of both worlds, minimal incision, but optimal mesh placement. Okay, one last area, emergency cases. What happens when a patient comes in, not for an elective repair, but with their bowel trapped and potentially dying incarceration or strangulation, time is short, contamination might be present? What's the rule then?
These emergency situations almost always demand an open repair, not keyhole. And the overriding surgical principle here is damage control, patient safety first. The rule is absolute. If there is established strangulation, meaning the surgeon finds bowel that looks dusky, compromised, potentially dead, or if there is any evidence of contamination, like pus or a hole in the bowel with leakage, then mesh must be avoided entirely.
You cannot put mesh in, even if you know the hernia will almost certainly come back without it.
Yes. You prioritize saving the patient's life and preventing catastrophic infection over achieving a durable long-term hernia repair in that moment. Placing prosthetic mesh, a foreign body, into a contaminated surgical field is asking for disaster. It almost guarantees a severe, deep-seated mesh infection, which could be life-threatening itself or require multiple massive operations to clear out.
Wow.
So in those urgent, contaminated situations, the surgeon focuses on dealing with the bowel issue, maybe removing the dead section, and then performs a simple suture repair just to close the hole in the abdominal wall. They accept the near certainty of a hernia recurrence down the line.
And plan for a proper fix later?
Exactly. The definitive complex mesh repair is then meticulously planned and performed electively at a much later date, maybe 6 to 12 months later, once the patient is fully recovered and the risk of infection has completely subsided.
That really highlights the complexity, doesn't it? Sometimes you have to accept a planned short-term failure, the recurrence, to ensure the patient's long-term survival. Hashtag tag outro.
So let's try and synthesize the most critical nuggets of knowledge from this deep dive for you, the listener. What should you take away?
Okay, first, I think it's remembering that fundamental biological flaw. The abdominal wall is permanently weaker, maybe only 70% of its original strength, after being cut. This makes patient optimization, especially that aggressive weight loss to lower internal pressure and absolutely mandatory smoking cessation, incredibly crucial before any elective abdominal surgery.
Absolutely. Second, that revolution enclosure technique is real, it's quantifiable, it's precise. Modern guidelines are built around that small bite method and is codified by that measurable standard. The suture length to wound length ratio must be 4.1.
Yeah.
That's key to minimizing tension and preventing that disastrous suture cutout.
Right, the 4.1 ratio. And third, for repair, success really hinges on choosing the right mesh, lightweight, large pore, and putting it in the optimal place. That retromuscular plane behind the muscle is generally preferred because it uses the body's own internal pressure to help hold the mesh securely.
And remember the mesh contracture, it's the body's scar tissue shrinking, not the mesh itself that's often the real culprit behind late recurrence and chronic pain.
Okay. It feels like the ongoing challenge of incisional hernias is really forcing the surgical world to confront the limits of the body's natural healing power.
It really is. The failure rate, the recurrence rate, even after decades of trying different techniques, has remained stubbornly high. And that's pushed us towards a new kind of surgical philosophy, I think.
A philosophy that sort of admits that for suing high-stress situations or high-risk patients, the body's natural 70% repair just isn't good enough.
I think that's exactly right. This persistent structural failure is why we're seeing this strong, sustained shift towards being proactive, towards prophylactic techniques intervening before the problem even starts by putting mesh in high-risk patients who haven't even developed a hernia yet. And it strongly suggests that the future of complex abdominal wall surgery will likely focus less on just reacting to failure and patching holes and more on preventing failure biomechanically, right from the very beginning, maybe using material science as a standard reinforcement.
So the final thought to leave you with, what does this increasing acceptance, this technical sophistication of prophylactic mesh really tell you about the future of how we approach complex surgical healing? Are we heading towards a model where maybe every high-risk abdominal closure routinely includes some kind of material reinforcement just as a standard engineering practice? Something to think about until our next deep dive.